straight away, or we'll start with the disturbances in body fluids, then we'll finish with immunology, immunopathology. So of course, when you talk about immunopathology, there's a whole subject on immunology, which basically is a whole subject even people do and get PhD on immunology. So it's a large topic that what we are doing basically is just introducing. And of course, you are encouraged to continue reading as you move on in your professional life, as you move on to the clinical years and so on. It's advised that, or it's expected that you continue revising on this. Yeah, so starting with the disturbances of body fluids. Yeah, so we're going to look, the main one we're going to look at is edema. As you can see, some people will spell it with an O, others will just use the E, but it's the same thing, edema, then dehydration, and overhydration. So edema, I'm sure we had already mentioned this even before, so basically just taking some more details. Basically, edema is an abnormal and excessive accumulation of free fluid in the interstitial tissue spaces and serous cavities. So interstitial tissue spaces is basically spaces between cells. Yeah. So basically what I was saying is interstitial spaces are basically spaces between cells. And when you talk of serous cavities, will include like pleural cavity, that is the chest cavity, peritoneal cavity, that is the cavity within the abdomen. And then we have the pericardial cavity, which is that space between the heart and the pericardium. So if you have fluid accumulating in the spaces between cells or in those cavities, the chest cavity, the abdominal cavity, the pericardial space, then that will be edema. So in the body cavities, if it is in the peritoneal cavity, that is within the abdominal cavity, you call it ascites. And then if it is within the pleural cavity, you can call it an hydrothorax, that is basically water within the thorax, or you can call it pleural effusion. Yeah, so when you talk of pericardial effusion, basically the fluid, the excessive fluid accumulating within the pericardial cavity. Remember we talked about pericardium, where there is visceral pericardium, and then there is the parietal pericardium. Then there is that potential space called the pericardial cavity. So if there is accumulation of fluid there, then you have pericardial effusion. And you can imagine that if there is excessive accumulation, then you will have compromise. You will have pericardial tamponade. That is the heart will be affected by pressure. So the interstitial spaces, I've already said, is basically between the cells, the spaces between the cells. So in this case, when we have edema, especially in the limbs, the lower limbs or the upper limbs, this edema can either be pitting or non-pitting. That is, if you are to press the swollen part, and then you lift the finger, there remain a pit there. So that will be pitting, and then one would be non-pitting. And also edema can be also divided into, can be termed as localized. So when you talk of something localized, basically is limited to an organ or within just that organ or within that limb. So it's not going beyond that. So if it is the lower limb, maybe one lower limb, it's just within that limb. If it is just within an organ, it's within that organ. So it's localized. So you can talk of it as being localized or generalized. That is affecting the whole body. And that one you can term it anasaka or you can call it dropsy. So it is systemic in distribution. For example, in scenario of renal edema, that is edema that is associated with renal failure, you have the entire body affected because there will be disturbance in electrolytes and it will affect the entire body. And so you will have generalized edema in that case. So that will be called that will be termed generalized edema. Then of course we can have special forms of edema. For example, pulmonary edema, that is basically the edema within the lungs. That is basically fluid accumulating. Remember the lungs, there is the parenchyma of the lung where there is the alveoli. That is the air spaces where gaseous exchange takes place. So usually when edema, when there is excessive fluid, it can accumulate into these air sacs. And so you end up having what we call pulmonary edema. And of course you can imagine what will happen when you have pulmonary edema, fluid filling those air spaces, you'll have difficulty in breathing because there will be nowhere for gaseous exchange to take place. Of course, you can also have edema within the brain. So between the brain cells, or even entering into the brain and cells themselves, or between the cells in the brain. So that will be called cerebral edema. And sometimes this is common, especially after injury. After head injury, sometimes we have cerebral edema. And this will be seen even in a CT scan of the head. After head injuries, most of the time we do severe head injuries, we tend to do CT scan of the head. And then from the CT scan of the head, you can be able to discern an edema. If you have edema of the brain, you can actually be able to discern it. You will be able to see, remember in the brain, we talked about sulci and gyri. And so when there is edema in the brain, these sulci and gyri tend to flatten. Actually, the sulci tend to flatten out when you look at it. So that will suggest edema in the brain, cerebral edema. And then, of course, what we had already discussed, which I had given you as the assignment, the type of edema fluid, the transudate and the exudate. So transudate will be most common, for example, the edema of cardiac or renal failure. So when there is cardiac failure or the heart failure or kidney failure or renal disease, you will have transudate. The kind of edema that you're going to have will be transudate. And then the exudate mostly will be inflammatory edema, especially in the scenarios of, for example, infection. Of course, including other inflammatory conditions that you can have. And there we have the transudate. So these are some of the characteristics that require you to bring that time, and even more. Of course, there are more, but this would be the main one, the differences. So by definition, you talk of the transudate being an infiltrate of blood plasma. That is basically blood plasma is the liquid part of blood without changes in endothelial permeability. So the endothelium, that is the lining of the blood vessels, that is basically the epithelium of the blood vessels, there is no change in permeability. That basically the cells are still held together, the epithelial cells are still attached to each other. There is no that permeability. And in this case already we've said it's non-inflammatory. And then in this case, the protein content, that is, if you are to look at this transudate, this fluid, you'll find that the protein content is low, less than 1 gram per deciliter. And the type of protein that will mainly be there will be albumin. And then when you look at the glucose content, that if you are to measure the glucose content in this particular, in the transudate, it will be the same as that in plasma. That is, if you are to measure the normal blood plasma, the amount of glucose that is within it, and then you measure the amount of glucose that is in transudate, they'll be the same. And then the specific gravity in this case will be low, less than 1.015. And then the pH will be high, more than 7.3. So in this case, it would tend to be basic, that is alkaline in nature. Then in this case of transudate, the cells will be few cells, and these cells will mainly be endothelial cells and cellular debris. So examples that have already been given is in the congestive cardiac failure, that is the heart failure. Yeah, there are different types of heart failure which you'll come to as you move on in your profession. You learn different types of heart failure. So one of them is congestive cardiac failure. That is basically there is excessive retention of blood within the heart itself because the heart is not pumping as it should. So there's a lot of backlog of blood within the heart. So it becomes congested. And mostly these tend to have backflow into the lungs. And so you end up also with pulmonary edema at the end of the day. So that would be congestive cardiac failure. Then the exudate, this one mainly is the definition is described as the edema of inflamed tissue associated with increased vascular permeability. So in this case, the endothelium, that is the epithelium of the blood vessels, will tend to part, as in there will be spaces between them. So that is, there will be increased permeability. So the character of the fluid will be inflammatory edema, inflammatory in nature. Protein content will be high, 2.5 to 3.5 grams per deciliter. Then if you are to measure the glucose content, and this one you are comparing with the plasma amount of glucose, it will be low, less than 60 milligrams per deciliter. Then specific gravity would be high, more than 1.018. And then the pH will be less than 7.3. That is basically it will be more acidic as compared to transudate. And then in this case of a exudate, the cells there will be many cells, inflammatory cells as well as parenchymal cells. So the cells that is making up the functional part of the organ that is specified, and some of them will be inflammatory, like for example neutrophils, all those white cells that during inflammation they are attracted to that place. So example that I give here is a purulent exudate such as pus. So in case of pus, an abscess, pus accumulating somewhere, so that pus will be purulent. That will be an example of an exudate. So looking at the pathogenesis, when you look at pathogenesis, that is how edema develops. Yeah, pathologically, how it develops. So one way is that there may be decreased plasma oncotic pressure. So in this case, you're looking at, when you talk of oncotic pressure, you're talking of basically pressure within the blood vessels. That mainly this one is caused by presence of proteins, for example, albumin. So generally, you know that if there is a lot of albumin, maybe within the blood plasma within the blood vessels, as compared to the protein that is outside the blood vessels, then you know basically because of the principle of concentration. So if there is more plasma proteins, then that will tend to pull water out from outside the blood vessels into the blood vessels. If there is more proteins outside the blood vessels and there is less within the blood vessels themselves, then the net effect would be for things to move out of the blood vessels into the interstitial spaces. So in this case, for example, when there is liver failure, most of the proteins are made in the liver. And so if you have a liver failure, then there will be very little protein that is made. So there will be little proteins within the blood vessels. And so you end up with, that oncotic pressure will be low. Likewise with protein malnutrition, in case, for example, of kwashiorkor, for example, I think when you rotate in pediatric ward, you'll be able to see children with malnutrition. We call it protein energy malnutrition, for example, kwashiorkor. And so you realize most of those children actually will look edematous. They will look like there's a lot of edema and usually tend to be generalized. Yeah, so that will be because of, if you have malnutrition, definitely there'll be little proteins within your blood. And so now that there will be the decreased plasma oncotic pressure. Likewise with nephrosis. Nephrosis is basically injury to the kidney. And so a lot of proteins will be lost. Most of the time within the kidney, you rarely lose proteins. But in case where there is nephrosis, that is injury to the kidneys, you are likely to lose proteins. And so you end up with low proteins within the blood. And so that will have decreased plasma oncotic pressure. Likewise with burns. When you have burns, you lose a lot of proteins outside the blood vessels. And so you end up with decreased oncotic pressure. And so when you have that, most of the fluid will move out into the tissues as a result. And so you end up with edema. So another mechanism of formation of edema will be increased capillary hydrostatic pressure. So increased capillary hydrostatic. When you talk of hydrostatic, it is referring to water. Yeah. So for example, so if there is increased pressure inside the blood vessels, the net effect will be to try and push fluid outside the blood vessels into the tissues. And so you end up with edema. For example, in scenario of congestive heart failure, so there's a lot of backflow because the blood is not moving well. It's not moving well to the right heart, or it tends to accumulate within the right heart and it's not being pumped properly. So basically there will be a backlog. It's like you are damming blood. So there's a dam. So there's a lot of backflow into the blood vessels. And so there will be increased pressure within the blood vessels. They will tend to force, the net effect will be to force water out of the blood vessels into the interstitial spaces, into the tissues. And so you end up with edema. Another way is of increased hydrostatic pressure will be in situation of cirrhosis of the liver with portal hypertension. So if you have cirrhosis of the liver vessel will be scarring within the liver. As I told you, one of the main causes or major causes of cirrhosis of the liver would be alcoholism, chronic alcoholism or excessive use of alcohol that eventually injures the parenchyma of the liver, and then you end up with fibrosis as part of the healing process. And so when you do that, remember there is the portal vein that takes blood from the gastrointestinal system to the liver. So because of pressure, because of fibrosis within the liver, then there'll be a lot of pressure within the portal vein. And so you end up with portal hypertension. So that was one of the ways that you will end up with capillary hydrostatic pressure, because there will be pressure within the liver, and so you'll have a lot of backlog within the portal vein. So you end up with portal hypertension. So another way would be lymphatic obstruction. Remember, one of the things that takes away excessive fluid from the interstitial spaces, that is between the cells, will be lymphatic vessels. And I think we talked about it in Anatomy 1, lymphatic vessels. So they're supposed to take the excess lymph fluid and then eventually end up into the blood system again. So if you obstruct those lymphatic vessels, for example, in filariasis, there are some, these are parasites, which I'm sure you will be able to start when you come to parasitology. We have filariasis. One of them we call, I think, Wuchereria bancrofti. You'll be able to see it when you do parasitology. So it's one of the parasites that block the lymphatic vessels. And so you end up with blockage of those lymphatic, and you end up with edema. So basically, fluid will, the excess lymph will remain within the interstitial spaces. And also in cases where we do surgical removal of lymph nodes, for example, during mastectomy, that is removal of the breast because of breast cancer, most of the thing that we do what we call axillary dissection. That is, you go to the axilla and remove all the lymph nodes there. So in the process, of course, you injure and you block those lymphatic vessels. And so in such a scenario, you end up with lymphedema, especially of that limb, that hand, that upper limb that is affected. And then also you can have malignant involvement of lymph nodes. That is malignant, maybe metastasis. We have already talked about malignancy. That these metastases can metastasize to the lymph nodes and even the lymphatic vessels and block them. And so you end up with backlog of lymph node, lymph fluid. You end up with excessive lymph fluid within the interstitial spaces, and then you end up with edema. Then you can have tissue factors as one of the pathogenesis of edema, basically increase oncotic pressure of interstitial fluid and decreased tissue tension. So within the tissues, tension is decreased, but there is increased oncotic pressure within the interstitial fluid. And so you end up with edema. And then also you have increased capillary permeability. For example, in situation of inflammation. So if you have inflammation, and already we did about inflammation, so there is that increased capillary permeability. So a lot of fluids will get out into the interstitial tissues, and you end up with edema. Also in situation where we have sodium and water retention, for example, in congestive heart failure, there's a lot of retention of sodium. And so when you retain sodium, likewise with renal failure, wherever sodium is retained, water tends to follow it. So wherever sodium is, water will go there and accumulate. And so you end up with edema. And of course, you can see the diagrams there, diagrammatic representation of the various mechanisms, pathogenesis of edema. You can see the normal fluid exchange there, where you have the HP is the hydrostatic pressure, and then the OP is oncotic pressure. So you can see in the normal is well balanced. But you see in that case where there is decreased plasma oncotic pressure, so the oncotic pressure within the plasma decreases. And so generally, because the proteins outside the blood vessels will be more, so the water will tend to move out into the tissues. And so you may end up with excessive fluid within the tissues. Remember, in that case, the lymphatic is still working, but if there is excessive, then there will not be enough lymphatic vessel to carry it away fast enough. So you end up with edema. You can also have increased, that is hydrostatic pressure. The hydrostatic pressure, that is the capillary pressure. The pressure within the capillaries is increased. So they will push a lot of water fluid outside. the blood vessels, and so you end up with edema. And then also you can have a situation where lymphedema basically is talking about the lymphatic vessels obstruction. So the lymphatic vessels there is obstructed. Hydrostatic pressure, oncotic pressure may be normal, tissue tension normal, and so on. But now the lymphatic vessel is blocked. So you end up with lymphedema, or you end up with edema still as one of the pathogenesis. Then tissue factors where you have a decreased tissue tension, and then we have increased oncotic pressure. That is basically the proteins outside the blood vessel is increased in number as compared to the, so in the blood vessels, the oncotic pressure is normal, but outside it, that is in the interstitial tissues, the proteins have increased. So you have increased, and then the tissue tension, that is basically the pressure within the tissues, has decreased. So that will encourage a lot of fluid to come out of the blood vessels into the tissues, and you end up with edema as well. And then now increased capillary permeability in cases, for example, infection or even other inflammation, whatever it is that can cause inflammation, is likely to cause capillary permeability to increase. And so you end up having a lot of spaces for fluid to come out of the blood vessels into the tissues. And that can lead to edema as well. Of course, we have a special kind of edema diagraphically shown there. I told you one of the special types that we talked about was pulmonary edema and cerebral edema. So this one basically is showing an example of pulmonary edema. Remember, there is the alveoli. Alveoli is where the gaseous exchange takes place. And usually at the alveoli, the endothelium just tends to be one cell thick for ease of diffusion of oxygen into the blood vessels and carbon dioxide coming into the alveoli for the purposes of gaseous exchange. So it's the capillary. Around the alveoli, always there will be capillaries. So in the first one, you see it's normal, the pressures and all, and so the alveoli is normal. There is no fluid within the alveoli. But when you go to the next one where there is increased pulmonary hydrostatic pressure, that is basically within the blood vessels, within the liver, the lungs, that is the pulmonary vessels, the hydrostatic pressure is increased. And so that will force a lot of water into the interstitial space until you end up with interstitial edema, of which also it crosses into the alveoli. And so you can see the alveoli now, there is edema, there is fluid within the alveoli. And so such a person, of course, if it is extensive, will have difficulty in breathing because all the alveoli will be filled with water. So basically like somebody drowning literally in the water there, because the alveoli are filled with water. It should usually just be filled with air for gaseous exchange. And then you can see in the next case where there is increased permeability. So likewise, it will within the capillaries, within the lung, there will be there is permeability. So a lot of fluid will get out into the interstitial space and also into the alveoli. So you end up with interstitial edema and also edema within the alveoli. And so it will, in this case, somebody will have difficulty in breathing because the air spaces or the alveoli are filled with fluid. That is just a micrograph. That is a histopathology, histology. On the left is the diagram, but on the right is a micrograph. That is a real picture. And you can see it's H&E. And I know about the staining, which we talked about, and this is like times 200. So that's the magnification. And you can see there is the edema fluid. Those are spaces are the alveoli, the air spaces. And you see those ones are the walls where the blood vessels will be. And so when there is edema, the water gets out of the blood vessels and enters the interstitial space and even into the alveoli. And so you end up with edema, pulmonary edema. There's what we call lymphedema. Most of the time we talk of lymphedema resulting because of obstruction of lymphatic vessels. So when you have obstruction of the lymphatic vessels, a lot of interruption. So you can see that lymph basically has edema, so it's called lymphedema. And then the next you can see is still lymphedema, but it's excessive. Most of the time we call it elephantiasis. You can see it looks like the leg of an elephant. I believe all of us have seen an elephant. So because this basically, this is an advanced stage of lymphedema. So most of the time it could be caused because of filariasis blocking the lymphatic vessels. And I'm sure probably some of you probably have seen patients with what we call elephantiasis, basically lymphedema, and it's because of obstruction of lymphatic vessels. Could be many causes. One of them, of course, is the filariasis, that is infection by those parasites that tend to block the lymphatic vessels, and you end up with elephantiasis or lymphedema. And then you can see, I was talking about the edema that is within the interstitial place. If you can have one being pitting or non-pitting. You can see in that lymph, somebody pressing on it, and then when you lift the finger, you can see a pit remains there. That is called pitting edema. I know one of the things that we do when you are told to examine a patient, of course you do general exam. One of them is you check for edema. And you check at the limb, maybe at the foot, and many other places where you can check whether there is edema. And then you should be able to describe whether that edema is pitting or non-pitting. That's one of the things that we check, including, of course, vital signs, including temperature, including blood pressure, pulse rate, including lymphadenopathy. You're looking for enlarged lymph nodes. Those are some more, including pallor, whether somebody is pale, whether somebody is jaundiced. Those are some of the things that when you're examining a patient, after general exam, you check for many things, including now the edema. And then we move on to dehydration. Basically, when you look at dehydration, hydration refers to fluid, adding fluid. So if you talk of somebody being dehydrated, that means you've lost water. So basically, dehydration is a state of pure deprivation of water, leading to sodium retention and hence a state of hypernatremia. So usually when you lose water, the body, one of the reaction of the body is to retain sodium. And when you retain sodium, usually water should follow. So basically it's an attempt by the body to return the fluid. And so when you have retention of sodium, you end up with what we call hypernatremia. Hypernatremia is high level of sodium. So if you do urea and electrolytes, you'll see the sodium level is very high. So that is what we call hypernatremia. The opposite will be hyponatremia. That is very low sodium level. So there's only loss of water, but no loss of sodium. So in this case, the sodium is not lost. It's only water that is lost. And of course, signs and symptoms. We talked about signs. Signs is what the patient will feel. Symptoms is what the patient will say they are feeling. And then the signs is what the clinician will elicit. So in this case, if somebody is dehydrated, they will probably feel a lot of thirst. And if it is excessive, somebody may even become confused. They may have fever. They may have oliguria. Oliguria is decreased urine output. Yeah, oliguria is decreased urine output. In fact, if it is completely no urine output, we call it anuria. So oliguria is low urine output. So if you are supposed to maybe be able to get about maybe 1,500 mLs of urine in 24 hours, maybe you end up with maybe 100. That will be oliguria. Yeah, and anuria is 0, no urine, for example, in 24 hours. So that will probably suggest renal failure. So some of the causes, what are some of the causes of somebody becoming dehydrated, losing water? One of them is GI, is gastrointestinal excretion. For example, vomiting. So if you're vomiting excessively or you're having diarrhea, basically loose stool, cholera, one of the things about cholera is you have an excessive watery diarrhea. So you are losing a lot of water. In any diarrhea, you're losing water. In vomiting, you're losing a lot of water. So if it is not arrested, then you end up becoming dehydrated. Also in scenario of renal excretion, for example, in situation of acute renal failure, in diuretic phase. Diuretic phase is initially when renal failure starts, actually you may be getting a lot of excessive urination initially before it shuts down completely and then there is no urine. That's what we call diuretic phase. Diuresis is lost. In fact, there are some drugs we call diuretics. For example, Lasix, which are, I think once you study, if you've done it pharmacology, you are likely to have been told about diuretics. For example, Lasix, among others, that if you are to take them, it causes you to pass a lot of urine. So it's called diuretic. So in that phase of renal failure, the early phase, you are likely to lose a lot of water. Also, extensive use of diuretics. I've told you already about diuretics, which is basically drugs that help you remove a lot of fluid. For example, if somebody has edema, one of the treatment that you do is to give them those diuretics. For example, Lasix, to try and cause them to urinate a lot so that you remove excess fluid in the body. So if you use excessive diuretics, then you are likely to lose a lot of fluid, a lot of fluid through urine, and you end up becoming dehydrated. Also in some endocrine disease, for example, diabetes insipidus. In this diabetes, you remember in diabetes mellitus, then we have diabetes insipidus. In this case, there is just a problem with the brain causing you to lose a lot of water. But in diabetes mellitus, the one we know, is because there is excessive glucose within the body. So you have excess glucose within the body. And so you end up, glucose in itself is like a diuretic. So it causes you to lose a lot of water. Also, if you were in a situation of loss of blood and plasma, for example, in severe injuries, if you bleed a lot, you know, the largest percentage of our blood constituent is water. So if you lose excess blood, for example, from bleeding, from injuries and so on, so if it is not well controlled, you end up with becoming dehydrated. Also severe burns. If you end up with burns maybe up to 40%, 50%, severe burns, you lose a lot of water in burns. And that is why in burns, one of the things that we do in severe burns, we give fluids, we give intravenous fluids to the patient that is involved with the severe burns. Also during childbirth, of course, during childbirth, you are likely to bleed, especially if you are not giving birth in a hospital setting and you develop what we call postpartum hemorrhage, PPH. You are likely to bleed a lot and lose a lot of blood and become dehydrated. Also loss through skin, for example, excessive perspiration. That is, for example, if you have a very hot area where you are sweating excessively, so you lose a lot of water through sweat and you may end up being dehydrated. Also hypothermia is the same thing. Hypothermia is very high temperatures. Yeah, so you end up sweating a lot and losing a lot of fluid. The opposite of hypothermia would be hypothermia, where there is very low temperatures. Of course, both of them are just as dangerous. Also, the way you can lose fluid and become dehydrated is through accumulation in third space. For example, if you have sudden development of ascites, so that spaces are like places like in the abdominal cavity, in the chest cavity, the peritoneal cavity. If you lose a lot of water into the peritoneal cavity, for example, in the intestinal obstruction, there is excessive accumulation of fluid within the intestine itself, but it's outside the cells. So you end up, that's what we call that space. So it is outside the cells. So you become dehydrated in such situation. So morphological features is what you will be able to see in a situation that of dehydration. Things that you can see grossly and things that you may need to do in a blood test, things that you will be able to see in under the microscope, for example, like in this case, if it is severe dehydration, in advanced cases, the organs actually may look dark if you look at it grossly, and they may look shrunken because you can imagine they've lost a lot of water. And then if you are to do full hemogram is where you're looking at the hemoglobin level, you're looking at white cells, red blood cells, all those cells constituents, the blood becomes hemoconcentrated. So basically there's a lot of loss of fluid. And so the plasma part of the blood will be less. So it becomes, that is what we call hemoconcentration. That is basically blood, concentrated blood. So if you look at the PCV, that is packed cell volume, it will be increased in the case of hemoconcentration. And also the hemoglobin is likely to be high. So you may find the normal hemoglobin may be up to 10, maybe 12 to 15. So if you find somebody with a hemoglobin of maybe 20, and maybe they've been involved in an accident, they've lost a lot of blood, that hemoglobin may be low. It may be that this patient is just hemoconcentrated because of dehydration. So in late stages of dehydration, you may have blood urea and even serum sodium being elevated because basically of concentration. So in later stage also you can have renal shutdown. That is basically the kidneys shut down, the kidney completely fail, and then a state of shock may develop. And I think we talked about shock last time, basically where you have a low blood pressure, and then you have a very decreased perfusion of tissues. So in severe cases. Then you can have the opposite, which is overhydration. That is basically somebody have excess fluid. Somebody is given, there's excessive fluid. I doubt whether you can drink. Maybe somebody can decide to drink a lot of water. It's unlikely that you will drink water until you become overhydrated. It's unlikely. So the most common cause would be increased extracellular fluid volume due to pure water excess or intoxication. So whatever reason causes to have excessive fluid getting into your body. For example, if you're giving somebody intravenous fluid and you give excessive fluid, then somebody is likely to become overhydrated. So increase extracellular fluid volume due to pure water excess or intoxication. So some of the signs and symptoms or symptoms will be nausea, vomiting, headache, confusion. Somebody may even have convulsion, that is seizures, as in somebody convulsing, like somebody who has epilepsy, for example. Somebody may even go into coma in overhydration, and even death can occur. So that is why it's important that you are careful when you're giving intravenous fluid, IV fluids. For example, one of the causes here could be etiology is cause, as we have talked about, excessive and monitored intravascular infusion. So as a nurse, if you're giving fluids, you just pump fluids, no more saline, you're giving excessive, you are likely to cause somebody to become overhydrated. And it can cause problems. It can even cause pulmonary edema. So you can also have renal retention of sodium and water in cases of congestive heart failure or chronic renal failure. So there's a lot of retention of sodium, and so there is a lot of water accumulating within the body, and so you become overhydrated. So if you're to look at morphological, what would you be able to see in a scenario of overhydration? You're likely to gain weight because there's a lot of water being retained within the body. And then reduce plasma electrolytes. Electrolytes are like sodium, potassium. Those are electrolytes within the blood. So it's likely to be reduced because of basically dilution. So there is lowered plasma protein because of dilution. Reduce packed cell volume. That is, the hematocrit become reduced. You can even have hemoglobin level being very low, not because it's actually low, but it's because of dilution. Like if you had the same, but you're putting a lot of water, then it will be, the electrolytes will have to appear less. Everything will appear less just because of dilution. There being excess fluid within the body. And then, so we move on to the next, which is basically an introduction to immunology. Yeah. And already, of course, we have touched on immunology before. When we looked at the cells, we talked of part of the cells, especially the white cells. One of their functions really is defense. Especially the white cells, part of their function is to defend the body. So here you are you're thinking about like the army, that the defense mechanism of the body, which is immunology. As I said, it's a whole topic by itself. We have people who are professors in immunology. At least in medical school, we are taught in first year, I think, and second year, immunology. One of the things we used to do is immunology by a professor of immunology. So it's a large thing that it cannot possibly be finished, but it is just good to introduce to you so that you can go ahead and read more. Because immunology, you cannot run away from it. When COVID came in town, basically we talked about immunization, we talk about vaccines. Basically, this vaccine and its understanding, you really have to understand immunology if you have to be able to understand issues about vaccines and so on. And we are all being given vaccines. There is the KEPI program, that is for the Kenya Expanded Program of Immunization for all children, BCG, all that. I know many of us got all those immunizations. Basically, that is immunology. So it's a study derangement of immune. So if you talk of immunopathology, you're talking about that derangement of the immune system. But of course, that means that you need to look at the immune system, understand it first, because you can look at the derangement or the diseases of the immune system. So what's the definition if you are being introduced into immunology that you need to know? So if you talk of, for example, an antigen, sometimes written as AG, is a substance, usually a protein in nature, which when introduced into the tissue stimulate antibody production. So when this antigen is put into the body, it could be, for example, a bacteria getting into your body, the body will react by producing antibodies. That is basically a protein that act now against that antigen. So antigen could be anything, a bacteria, a foreign body, could be a virus, could be anything. Yeah. So when you talk of an antigen, it's a substance, usually a protein in nature, which when introduced into the tissues, stimulate antibody production. Hapten It's a non-protein. So in this case, this is non-protein substance, which has no antigenic properties. By itself, it has no antigenic properties. So even if you are to put in the body, by itself, it doesn't cause the body produce antibodies. But on combining with a protein, so if this is combined with a protein, it can form a new antigen. So it now becomes an antigen. So you have a substance, a protein substance, then you add, combine with a protein, you end up with a new antigen capable of forming antibodies, causing the body to produce antibodies. That now will be a HAP10. So basically, when you talk of immunity, you're talking about the body defense mechanism. Antibody, when you talk of an antibody, you're talking about protein substance produced as a result of antigenic stimulation. So there is an antigen. What is produced against it is called antibody. So circulating antibodies are immunoglobulins. So antibodies that are circulating within the blood, we call them immunoglobulins, IgGs. And we have like 5 of them: IgG, IgA, IgM, IgE, IgD. So it will be your work to go and maybe read some more about that to know exactly which function do they perform. For example, IgG is more common in allergic reactions, for example. So an antigen, we already talked about the antigen, and this may induce specifically sensitized cells having capacity to recognize, react, and neutralize the injurious agents or organisms. So it may cause there to be production of specific cells that are sensitized, to be able to recognize, react, and neutralize injurious agent or organism. So it could be a bacteria or any other agent. So some cells actually sensitize specifically for that. And this antigen may combine with an antibody to form antigen-antibody complex, AG-AB, that is antigen-antibody complex. And this reaction may cause tissue damage. So this reaction in itself may cause injury to the tissues, even to the normal tissues by itself. Then we have the types of immunity. So as I said, of course, we have to introduce and look at what is immunity in the first place, the normal one, before you can go into the abnormal. So you can have an immunity, you can call it natural or innate immunity as one of them. It's basically non-specific. That means whatever antigen comes, it is able to attack it. So it's not specific for a specific antigen. So it's non-specific. Initially, it will be the first line of defense without antigenic specificity. So if something gets into your body, the first line of defense will be that one. And then the components, you have humoral. Humoral basically requires something that is floating within the plasma, the fluid. For example, complement. And then it consists of cells. For example, it consists of neutrophils, macrophages, natural killer cells. Then you have the specific or adaptive immunity. This one is specific, characterized by antigenic specificity. So the antigens that this particular immunity is able to attack specific antigens. It's programmed for specific, so it's specific. And that is the adaptive or specific immunity. Also, it has those two components, the humoral and have the cellular. Humoral consisting of antibodies formed by the B cells. So remember the antibodies. And then the cellular part, mostly mediated by T cells. So it will be your work really to look at those details of what are B cells, what do they do, T cells, look at them. So the various components of both types of immunity are interdependent and interlinked for their function. So they are interdependent, depend on each other. They are sometimes interlinked for their function, so that you wouldn't have really one. So when you look at the structure of immune system, so we have specific organs that deal with the immunity. For example, you can have primary lymphoid organs. For example, the thymus, the bone marrow, which you already mentioned. Those are primary lymphoid organs. Then we have some secondary lymphoid organs. For example, the lymph nodes. That will be in many places in our bodies, the axilla, the inguinal region, and so on. Those will be secondary lymphoid organs. The spleen also is one of our lymphoid organs that is considered secondary. MALT, mucosal associated lymphoid tissue located in the respiratory tract, and GIT. So for example, tonsils that we talked about is situated behind the mouth. Those are considered part of mucosa associated lymphoid tissue. And there are some around the nose, around the mouth, behind the mouth, even within, if also when you talk about the pairs patches, I think we talked about the pairs patches that are found in the terminal ileum, that is towards the end of the ileum. There are those pairs patches. I remember telling you that during an infection, like for example, typhoid, they tend to enlarge and sometimes they can even perforate. So those are MALT, mucosa-associated lymphoid tissue, and those are as part of secondary lymphoid organs. Then, of course, we have cells of the immune system. As we've already talked about, we've talked of lymphocytes. We have T and B lymphocytes, monocytes, and macrophages. Remember, monocytes, when they get into the tissues, they become macrophages. Those are they are able to engulf the various foreign bodies or even bacteria or viruses. Then we have mast cells and basophils. We have neutrophils, eosinophils. So it will be up to just look at some more details exactly on those types of cells, which we had mentioned even before when we did, I think, Anatomy 1. Then, of course, just mentioning in brief the diseases that can be there in the immune system. For example, you can have immunodeficiency disorders. For example, AIDS, acquired immune deficiency syndrome. So you have HIV, that it goes on to become AIDS. So in this scenario, mostly I think it is the white cells that are usually destroyed. You should be able to look at it. I'm sure when you go to the clinical area where now you're looking at specific diseases, you should be able to read more details about HIV and AIDS. And there are a lot of details out there, yeah, about this particular condition. And people have written a lot about. So in this case, because of cells being destroyed by the viruses, you end up with low immunity. So you end up with immunodeficiency disorders and many others. Not only AIDS that cause immunodeficiency. Even, sorry for the many interruption. So hypersensitivity reactions are things like basically allergies, hyperfunction of immune system. So yeah, so and you talk about hyperfunction, you're talking about hypersensitivity reaction like allergies. Yeah, and all of us have sometimes have developed allergies, sneezing, all that. Could be just the immune system is overreacting or it's becoming hyperfunction. Then we have autoimmune diseases. As we have said, the immune system fails to recognize self from non-self. For example, in diseases like ulcerative colitis and others. Basically, in this case, the body, the immune cells, for example, and so on, they don't recognize self. So they start destroying its own cells and tissues. And so that's what we call autoimmune diseases. That is basically the body attacking itself, so to speak. And then there are things like amyloidosis, so an abnormal accumulation of a specific type of protein, and it is thought that it could be an immune disorder. However, nobody is sure as yet, very sure yet, but it is thought it could be of immune origin. Yeah, so so thank you so much. I think we'll leave it there.